Hi, I'm Sally Ozonoff, Professor of Psychiatry and Behavioral Sciences at UC Davis and a faculty member here at the Mind Institute. Today I'll be presenting a talk about advances in the early diagnosis of ASD. This is an outline of what I'm going to talk about today. I'm going to begin going through some of the research and what it tells us about the earliest signs of autism spectrum disorder in infancy. Then I'm going to talk a little bit about recurrence risk, which means what the likelihood of having a second child who's affected is. I'm also going to talk about other outcomes that we sometimes see in siblings of children with autism, and finally some implications for parents. Now the whole point of this research, and for earlier identification, is that the earlier a child's identified, the earlier we can get them into treatment. The median age of diagnosis right now in the United States is still around 4 years of age, which surprises a lot of people, but the Centers for Disease Control does a study every other year where it looks at this, and even in 2014, the most recent study that they've done, the age of diagnosis was still over 4 years of age. Now, parents often tell us that they first notice difficulties with their child maybe around 18 months of age, and in fact, roughly a third of them even report concerns before the child turns 1 year of age. So we know we could do a lot better than diagnosis at age 4. We have 3 years in which children are showing symptoms but are not getting diagnosed for many of them. And what we really want to do is identify them as early as possible so we can get them into very high quality interventions when their brain is still really malleable and really changeable. So that's the whole point of this research. For a long time, the only way we could really understand what the very earliest symptoms of autism were was using retrospective methods. And these are things like asking parents, after their child's already been diagnosed, what they remembered about how the child was before the diagnosis. Saying things like, well, what were you thinking about his development when he was 9 months of age? Or what do you remember about how he was at 12 months? And these methods have some limitations. I, as a parent myself, can't remember half of that. And most parents are really pretty general in their recall. They sort of remember like, well, he seemed okay, or he seemed delayed, but they're not able to pull up exact dates, which is important for research. Now, another method that was used that was also retrospective is that we would collect videos from families that they'd been recording since the child's birth, not for any particular scientific purpose, but just to have. But then after the diagnosis of autism was made, we could go back and look at that video that was collected pre-diagnosis and see if we could find any signs of the coming diagnosis on the video. Now, that's a more precise method than parent report, but number one, it's very time consuming. It takes years and years to do it. And so it's really not very realistic as a method for most studies. And then secondly, a lot of families don't videotape their child, or if they're videotaping, they turn it off when the child starts acting in a way that they don't really want to remember. Certainly I did that. So if your baby starts crying, you think, oh well, we don't need this, and you turn the camera off. And so sometimes the symptoms wouldn't actually be on the videotape. So in the past decade or so, a new strategy has begun to be used much more frequently. It's really an exciting way to think about this. What we do is we follow samples that are at somewhat higher risk for developing autism, and we invite them to come into the laboratory when their baby's very young, and then we longitudinally follow their baby all the way through the window when the symptoms of autism start, and where we can then do probes over time for very particular behaviors that we know are associated with early diagnosis. And this graphic here shows two pedigrees, one of a family where they have an affected child with autism, that's the one on the left with the dark square, and then they're having a new baby. And so this is one type of high-risk sample that we can follow. So they already have a child with autism and a new infant born in the family, and so we could follow them. And we always compare them to families that don't have children with autism, so we're able to distinguish what the features are that are special in the child who's developing autism than in children who aren't. During today's talk, I'm going to tell you about some data that we've collected over the last 13 years in a multi-site study that was done at UC Davis in collaboration with researchers at UCLA. So across these two sites, we've studied now over 800 individuals, both at high risk for autism and at no family risk for autism. We see them at various time points, usually 6, 12, 18, 24, and 36 months of age. And then I've put in red here ages at which we do a very comprehensive diagnostic assessment to determine if the child has autism. We do actually diagnose autism earlier if the signs are evident, but for every child, no matter whether they've shown signs or not, we do a full diagnostic assessment there. You can see at 36 months. Now, some of the children have gotten a lot older because we started the study in 2003, and so for some of the children we've been able to see them back when they were 6 or 7 years old, and we do another diagnostic assessment then to determine, number one, did we miss any cases of autism? Number two, are any of the children who we diagnosed earlier not meeting criteria anymore? And number three, maybe have any of them developed anything that we couldn't pick up when they were preschoolers? For example, learning disabilities like dyslexia isn't diagnosable when you're a toddler. So then we look again to see if there's any new diagnoses. Some of the children we've even seen now when they're 9 to 12 years old for the oldest part of the sample. And I'm going to tell you about all of these results. So this study had three major goals. The first one is what the very earliest reliable markers are of autism. In other words, what are the first behaviors we could see that reliably predicted that this child was going to have autism? And how early could we see those? Could we see them at 6 months, at 12 months, etc.? Secondly, we also looked at if siblings of children with autism are at higher risk for developing autism themselves. And finally, what other developmental problems occur in this group. So I'm going to start off with our first one here, looking at how early we can identify risk signs. This slide shows a list of the many different measures or instruments that we use in our study, and I'm not going to go through each one, but the point I want to make here is we cast a really wide net because we're really not sure what autism could look like at 6 months or at 9 months. It might look like it looks in an older child, but it might not. And in fact, there's a lot of things 6 and 9 month olds can't do that older children can do. So we have to modify our measures at every single age. But you can see that we're looking at some areas that are really obviously related to autism, things like empathy, social responsiveness, imitation, eye contact. But we also are looking at some things that might or might not be related to autism. We have to test it to find out. So we're also looking at the child's motor abilities. We're looking at their head circumference. We're looking at how they scan faces, a whole variety of different things. I'm going to show you 3 videos now that illustrate not only the measures that we use in this study, but also how a child who is in the process of developing autism, and in fact is diagnosed with autism shortly after these videos were taken, how he performs on these tasks. So this is a little boy. He's 12 months of age, and in this first video we're just playing a game with him with an interesting object. The examiner is going to demonstrate how it works and then just sort of pause and wait a little bit to see if she can get him to interact with her, to communicate with her, to do things that 12-month-olds generally can do, to see if he might reach for it, if he might make some sounds or noises indicating that he's interested in it, and things like that. So you can see she has an interesting object there, and she just places it out of his reach. What she's expecting him to do is maybe to look up at her to indicate he's interested, or to gesture in some way to indicate that he wants it, maybe to reach for it or point at it, maybe to smile because he thinks it's interesting. But you can see that what he does actually is he only looks at the object. He never once looks up at the adults in the room to indicate or express to them that he thinks the toy's fun or interesting. And he doesn't communicate in any way with the examiner. So he doesn't gesture to her, he doesn't smile at her, and he apparently isn't paying very much attention to her. He's really paying attention to the object. So you can see that he's very, very captured by objects and isn't really doing much social interaction or communication. Okay, in the second clip that I'm going to show you, all we're going to do is call his name. And this is something that parents often tell us is one of the earliest things that they've noticed in their infant as they're becoming concerned about them, that when they call the child's name, they don't turn around and acknowledge them in any way. However, the parents will often say, but we know he's not deaf because if he hears the garage door go up, or if he hears like the crinkle of paper from a wrapper of candy or something he likes, he'll come right over. So we, in our study, wanted to test how well the babies responded to name at every single visit. So we didn't have to rely on whether they happened to or not. We were going to just test it systematically every single visit. So this is all that task looks like.
Jacob! 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 Can I get you to call his name from where you are?
Jacob. Jacob. Baby boy.
So you can see that he doesn't respond to his name when the examiner calls it. Sometimes it's the case that if a familiar person, like his father, calls the name, that babies will be more likely to respond. But he doesn't respond to his father either, and doesn't seem to even really be attending to the human voices, but is really, again, very captured by the object. Okay, and the final clip I'm going to show you here, same little boy at 12 months of age. We've given him some objects to explore, and we want to see what he does with them. Now, many of you might know that in older children with autism, it's common that they'll use objects in slightly unusual ways, like they might line them up, or they might tap them, or spin them, or do things like that. One of the things that we've always thought is that this was a later appearing symptom of autism that maybe you didn't see until a child was older. But again, we wanted to test it in this study and see how early could we detect this particular behavior. So you can see a couple of interesting things in that video. First of all, he does some very typical behaviors for 12-month-olds. Most 12-month-olds with that object will do some banging, just like he did, and that's really typical. But he also did a couple of things that were unusual, and that in fact our data, when we analyzed it across all of the participants in the study, did turn out to be predictive of a later diagnosis of autism. He did three particular things. One is he rotated the object from front to back multiple times. Another is that he really stared at the object very, very intensely. And then the third is he did some sort of spinning of it, where he would drop it and let it wobble while he watched it. And those three behaviors were much, much more common in little 12-month-olds who were developing autism and would be later diagnosed with it than they were in the 12-month-olds who didn't have autism later. This slide here summarizes all of our results across all of the different tasks we've done for the past 13 years. And you can see a pretty striking pattern here, I think. This compares all the children with ASD outcomes, of whom there are roughly 50 right now, compared to the low-risk infants, the children that didn't have any family history of autism. And you can see that there are no check marks, meaning that there were group differences in the column labeled 6 months. So in other words, every single measure that we've looked at every single instrument that we've looked at 6 months, there have been no differences between children who are later going to have a diagnosis of autism and children who are going to later be determined to be typically developing. But by 12 months, on every single test that we've given, there are group differences. So in every case, whether we're looking at language, processing of faces, imitation, synchrony with playing with the parent, eye contact, every single behavior we've looked at, on the average, the group developing autism is lower than the group of typically developing infants at 12 months. Now, the important thing to remember here is that this is on the average. So that group of 50 children on the average is different at 12 months. But individually, some children are different at 12 months and some are not. And that's a point I'll come to a little bit more in the talk. So these are average differences. This graph here shows some interesting data that we have that came from coding of the videotapes that I just showed you. What we mean by coding is that we have individuals in our lab who don't know anything about these babies. They don't know what their outcome is going to be. We have them analyze the videotapes very carefully, and they make very, very detailed counts of the number of times the child makes eye contact with the other person, the number of times that the baby smiles at the other person, the number of times that the baby vocalizes, makes some sounds or words towards another person, and they sit and count these off of all that videotape that we collect. We basically videotape every single thing in the lab. And what we have plotted here on these figures in red is all the children that have developed autism, and in blue, the children who are typically developing. And what you can see, if you look closely, is that at 6 months of age, there's no differences between those two groups on gaze to faces. In fact, if you look at it, the group who's going to eventually have autism actually looks at faces more than the children who are typically developing. There's no differences at 6 months in how much they smile at another person, and there are no differences in how much they vocalize at 6 months. But then if you look at how those trajectories play out over time, you can see that the children with autism show really big drops in their eye contact, their gaze to faces over time. So by 12 months, they're significantly lower than the group with typical development. They also show decreases in social smiling and decreases in vocalization. So what we take from this data, and from the data on the previous slide, where there were no differences on average at 6 months, is that there's a decline in the development of many of these babies, so that they're starting off with pretty age-typical behaviors at 3, 6, 9 months, but then over time they're decreasing in the frequency of these behaviors, so that they're sort of losing some of their eye contact and their smiling at other people over time. Now, this kind of data is very laborious to collect, and the coding of it takes a long time. So we also wanted to determine if there was a way we could potentially document this decline that wasn't going to be so difficult and challenging as coding. We asked the examiners, who, by the way, are unaware of which group the child's in, or any other information about them. They're kept completely unaware of those details. We asked the examiner at the end of each visit to make a rating of the child's social behavior. And that's what you see on this next slide here. So these are examiner ratings, and you can see the exact same pattern. At 6 months, the examiners rate the infants who are later going to get diagnosed with autism and the infants who are later going to be determined to be typical. They rate them exactly the same. Their scores are literally the same on a social engagement rating. But over time, the infants who are going to be determined to be typical, their scores on this examiner rating go up a little bit, whereas the scores for the children who are developing autism go down. And so the examiners over time are rating them as less and less socially engaged. And so this was good news for us. It meant that we could develop a rating system for examiners, or maybe even for pediatricians, that they could rate, and if we could see that a child's score on this was going down, it might alert us that there was a problem in their development. We replicated this recently with a newer set of data, and these are completely different children with autism who've been in the study. And this time what we plotted is all of the children who had been collected between 2010 and 2014. We didn't just have an average graph like on the previous graph. So here every line is an actual child with autism, and it shows how the examiner rated them over time. One of the reasons we did this is because we wondered if the curve on the previous slide there, which is averaged across 25 children, maybe it got pulled down by a few kids who had like a huge regression or a huge drop by some outliers, but maybe all the kids didn't, their development didn't decline in that way. We really wanted to see how many showed this pattern. So going back to our 2014 data, you can see here with a new group of 20 children that 18 out of the 20 showed this declining pattern over time, where they looked pretty similar to the low-risk group at 6 months, but then their eye gaze, for example, or their social engagement dropped over time. And there were only 2 children who had very low rates of social engagement already at 6 months. We also asked parents to do these exact same ratings in this new sample that we've collected between 2010 and 2014. So at the beginning of every single visit, the parent would fill out a form saying, today, based on how you see your child, tell us how socially responsive to you they are, how much they make eye contact with you, how well they respond to their name, and a variety of questions like that. And so the parents rated this prospectively every time they came in. They didn't have to use remember anything. They just did it based on that day, and we got it at every age. And you can see that it looks very, very similar as the examiner ratings, that the infants start off with pretty high social engagement ratings from their parents, but over time, those are dropping. And there's only 2 children, and in fact, they're the same 2 children who are rated by their parents as actually pretty low in social engagement, even right at 6 months of age. So this was exciting for us because it meant that maybe we could develop this measure to be used possibly in pediatricians' offices or things like that. Very similar to how a pediatrician measures a baby's head circumference at every visit. If they could do this kind of rating over time and then look to see any child whose score was dropping from visit to visit, that might be an indicator that this is a child who's at risk for autism. This is even another way of looking at this. This is based on a chart review. And what I mean by a chart review is that we had somebody who was completely outside the study, unaware of any of these children's identities or outcomes, take all of the data that we'd collected on the child at every single age, and sort of look through it, read all the reports, look at all the testing, and give them a rating. A green rating basically meant that the child seemed completely fine, there were no concerns raised in the report, the parents hadn't brought up any concerns, and all of their developmental testing was in the normal range. A yellow bar meant that some of those things were off. So either the parent was becoming concerned, or the examiner was, or the testing was starting to fall out of the typical range. And then a red bar here meant that the child actually had been diagnosed. And so if you look at this as a gestalt, what you see is that there's a lot of green over at 6 and 12 months, right? And there's a lot of yellow between 12 and 24 months, and then a lot of red. And so it's just another way to represent exactly the same phenomenon that I've been talking about, where basically the signs of autism are emerging over time. They're not just present at birth, they are sort of unfolding during the first year or 2 of life. Okay, let me move on to the second goal of our study, and that's looking at recurrence rates, or if the siblings of children with autism are at higher risk for developing autism themselves. Now, we did think the answer to this was going to be yes, because there had been some studies that were done in the 1980s and 1990s that suggested that the recurrence risk for autism was between 3 and 10%. If you think about the prevalence in the general population as being about 1%, then obviously children who have siblings with autism are at somewhat elevated risk, because 3 to 10% is up to 3 to 10 times higher than the general population risk. Yet during the same time period, the prevalence of autism has been going up, and we wondered if it's also going up in siblings, so we really wanted to look at these figures again. We're fortunate to be part of a network that collects data on infant sibling studies that are done all around the world, mostly in North America, the United States and Canada, but there are several sites that are in the United Kingdom, Israel, and parts of Europe. So in this particular analysis, we were able to pool data across 12 different sites around the world, and instead of having a smaller sample like the ones I've just presented to you at our site, and we were able to look at a sample of 664 children at high risk for autism and compare them to 338 low-risk infants, because we pooled data across all these sites. And we ended up finding that the prevalence of autism in siblings was significantly higher than those previous estimates, which were between 3 and 10%. In this study, we found that almost 19% of the high-risk siblings developed autism, which is much higher than those previous estimates. And then we found that the recurrence rate was higher still in male infants and in infants who came from a family that already had more than one child with autism. So the 18.7% figure is averaged across all of the children in the study, but some children had higher risk than 18.7% and some had lower. Let me explain that a little bit more. So in this figure, we've broken it down by the gender of the infant and also by the risk group they're in, whether they're high risk, so they have a sibling with autism, or low risk, they don't have a sibling with autism. And you can see that the rate of having autism for high risk males is actually about 25%. So I said earlier that the overall rate was 19%, but it's actually higher for boys. It's roughly 25%, whereas for girls it's about 9%. If you look at those two red bars. And in both cases, much higher for both boys and girls than in the low-risk group. This graph is indicating whether the infant had more than one older sibling with autism. So those are kind of families that are called multiplex families in the research world. That means they have 2 or more children with autism prior to the baby being born. Or simplex families, which have one child with autism and then a new baby. So you can see here that if the new baby is male, and if they're in a multiplex family, so that's on the left side of the graph, the red bar, their risk is actually almost 50%. So more than one sibling with autism, new baby as a boy, his risk is actually close to 50%. If it's a girl in a multiplex family, her risk is roughly 20%. Whereas if you are in a simplex family, if you're a boy, your risk's roughly 20%, and for girls, it's 10%. So this shows that these two factors, the sex of the new baby and whether they have one or more siblings with autism, is really, really informative in determining whether they're going to have autism themselves as an outcome. We looked to see if recurrence was predicted by other things, and it wasn't predicted by anything else. So we looked at whether the sex of the older child mattered, the older child with autism. So if your first child with autism was a girl, did that make you more likely to have a new baby with autism? No. We looked at whether the older child with autism, we call them the proband, whether they had a high verbal level or a lower verbal level. Did that matter at all in whether the new baby was affected? No. We looked at where the new infant fell in birth order, if they were the second child versus the fourth child. Did that matter? No. We looked at parent age. We looked at family ethnicity and race and family economic level. None of those things predicted whether the new baby would have autism. The only things that helped predict, on the average, were the sex of the new baby and whether there was already more than one child with autism in the family. Then the third goal of our study is looking at whether there are any other problems that occur in the siblings. So if the siblings don't develop autism, are they completely typical, or do they maybe struggle with other developmental challenges? So these two pie charts here show the rates of autism outcomes, similar to what I just mentioned to you, 17% at our site, and then the range of other kinds of outcomes in the high-risk group. So we grouped these together and called them non-typical outcomes, and that was 28% of the sample who had other problems in development, even though they didn't have autism. So they might have had some mild social difficulties like extreme shyness or really hard time interacting with non-familiar people. About 7% of them had speech and language problems that were requiring intervention. Actually, about 5% of them had behaviors already that looked like it might be ADHD. They were very hyperactive, very impulsive, and then just a very small proportion had global developmental delays. And this was a much higher rate, 28%, than we saw in the low-risk group, which only had about 9% of individuals who had similar kinds of problems. So almost 3 times higher. We saw this group back when they were 6 to 7 years of age, as I mentioned earlier, and the rate of these non-typical outcomes increased a little bit, not a lot, but it went from 28% to 32%. And the big jump occurred in the area of ADHD. So actually 11% of our sample who have older siblings with autism, they themselves meet criteria for attention deficit hyperactivity disorder. We also saw in many of these siblings that they had some mild social difficulties, peer problems, and things like that, but none at the level of having a full-blown autism spectrum disorder. This graph goes into a little bit more detail about ADHD. We've become really interested in this, and so we followed the sample again one more time when they were 9 to 11 years of age, and very specifically did a lot of testing related to ADHD because we wanted to be sure we were getting children diagnoses and help that they might need in school. And so you can see when they're 9 to 11 years of age that the percent of ADHD outcomes in that group is actually really high. About 40% of the sample who we've studied so far, 15 out of the 37 children met criteria, full criteria for DSM-5 ADHD, whereas only 3 children in the low-risk group did. And this just shows sort of their level of symptoms, not whether they met criteria or not, but just like the number of symptoms of inattentive behaviors they had, hyperactive impulsive behaviors, and then total symptoms. These are basically symptom counts, and you can see that in all cases the high-risk group who has older siblings with autism has higher levels of ADHD symptoms as well. Okay, so I'm going to wrap up now. There's a couple of important conclusions that you can draw from our study. The first one I mentioned earlier is that autism symptoms emerge during infancy and they emerge over time. There's very few markers of autism at 6 months or earlier, but signs begin to onset and development starts to decline between 6 and 18 months. The reason this is important is because it really gives us a window that we know is important to look for these signs. And in fact, if we could catch them before the full onset of all of the symptoms, maybe catch it early and get intervention for children, maybe even before they meet full criteria, possibly we could treat some of those symptoms so that they were so reduced that they really weren't impacting the child's development. A second conclusion is that it's really clear that having a sibling with ASD in the family is a risk factor for new infants that pediatricians should be aware of. Let me give you an analogy actually. If you are, you yourself as a parent are being seen by your provider and you have a family history of cardiac disease, right? You have maybe a parent or a sibling who's had a heart attack. They're going to do lots of testing related to your blood pressure and your cholesterol levels and things like that. And they might even start preventative interventions for you just based on your family history to keep you from getting cardiac problems yourself. And this is the way we think it should be viewed by pediatricians. If you already have a child with autism and now you have a new baby, your new baby on average has a roughly 20% chance of developing autism. So they should be looking out for impending signs of autism in the same exact way that an internist would be looking out for us as adults for signs of cardiac disease in a family that has a family history of cardiac problems. So infants and affected families really need to be closely monitored by their pediatricians. And finally, as I said earlier, the main point of all this, the diagnosis is really just a gateway to get treatment as early as possible. I've included a couple of slides here at the end for families who want to be aware of what the earliest social communication milestones are and what your baby should be doing at very early ages. And these are behaviors relevant to autism. I haven't put in all the behaviors, obviously, but just those focused on social communication, which is really the core of autism. So by 1 month of age, infants are very good at understanding that faces are important. They look at faces more than any other body part. And they also, even within the first month of life, hone in on the eyes within the face. They know that the eyes are central. They know that the eyes are more important than the nose or the ears or the hair, and they look at eyes right away. So if a baby isn't doing that, that's concerning. Between 1 and 2 months, babies learn how to smile at other people, and they do so very frequently, particularly with their parents and familiar people. At 3 months, they should be starting to coo. That's a term we use for when they have vowel kinds of vocalizations, things like ooh and ah, but no consonants in them yet. And they might do this in a little turn-taking pattern with parents, where the mother might make a sound and then the baby makes a sound and the mother, and back and forth like that. Between 6 and 9 months, the baby should start to introduce consonants into their babbling. So this would be things like ba, 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 da, 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 even if they're not using it to mean anything. And then between 6 and 9 months also, they should be responding to their name pretty regularly. 9 to 15 months, they should start to point and then use other gestures like shaking their head no, or reaching for things, or shrugging. And then between 12 and 15 months, they should imitate other people. So if a baby's not doing some of these things, and you can use a little leeway, a month or 2 or 3 on either side, but if you have a baby who's well older than some of these ages and isn't doing some of these things, it's really important to bring it to the awareness of your pediatrician. This is what we know across many studies, not just the studies done here at the Mind Institute, but across the world, that have pointed to the very earliest signs of autism. And I've summarized them here. These particular behaviors are significantly reduced or delayed in when they start showing up in development. Looking at faces, smiling at people, cooing, responding to name, babbling, playing social games. That's things like peekaboo, being very interested and excited about games like that, or I'm gonna getcha. Displaying bright affect. You see the little girl in the middle there, how her face is very lively and very expressive. You should see emotions like that on your baby's face. And then when they get a little bit older, they should be pointing. See that baby on the right there? She's actually wearing a My First Birthday hat. So you can see that she's 12 months old and she's really good at pointing. She's actually pointing to the cake and she's looking at another person to sort of say, hey, look at that. And your baby should be doing things like that, pointing, showing you things, and starting to imitate. I'm going to end here with some resources for you. If your child might have autism, there is a book I highly recommend by Wendy Stone and her colleagues called Does My Child Have Autism? And it's geared very much towards early diagnosis. There's also a very helpful book by Dr. Sally Rogers, one of my colleagues here at the Mind Institute, called An Early Start for Your Child with Autism. It's particularly geared to parents to give you activities you can work on at home with your very young child, even before diagnosis, or right afterwards as you try to get him or her started with talking and social engagement. And then there's a brand new book that just came out by Dr. Deborah Fine at the University of Connecticut, which has lots and lots of activities that you can do with babies, very young babies and very young toddlers, built into your everyday home routines that can help increase social and communication skills. I've also put a link to Autism Speaks, which has something called the 100 Days Kit, which is things that parents should know in the first 100 days after their child's been diagnosed, and ways to get you started with intervention and finding resources, as well as links can also be found at autismspeaks.org to Learn the Signs campaign. It covers some of the same information as today's talk. And there's also a video glossary where you can go watch more videos of children displaying particular symptoms if you have questions about things that your child's doing and want to see what it might look like in another child. I want to end with thanking, in particular, the families who've participated in this study. We've had over 800 families across UC Davis and UCLA participate. Most of them have been coming to our lab from their child's birth, now for some of these families through the age of 13 years, and we cannot thank you enough for your long-term support of this project. We have learned so much. And also to thank our funders and the wonderful infant sibling team who does all of this work. If you'd like to learn more on this topic, please visit our website under the Infant Sibling tab. We have an exciting new opportunity where we're studying infants who have older siblings with ADHD and are currently recruiting for that. So if you have a family member who's affected with ADHD, please feel free to sign up for our study.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.